Good morning. How are we doing, everybody? I want to thank you guys for joining us this morning, your final morning at the 2025 APSA conference. We're privileged today to hear from three different panelists: Dr. Kyle Van Arendonk of Nationwide Children's Hospital, Claire Abrahano, nurse practitioner from Stanford Medicine Children's Health, and Candy Fraudette, a nurse practitioner from Phoenix Children's. Their presentation, Advancing Pilonidal Disease Management, promises to share effective approaches and expertise in this challenging area of pediatric surgery. Please join me in giving them a warm welcome.
Good morning. So, pilonidal disease. It's a chronic inflammatory condition related to hair follicles and subcutaneous foreign body reactions in the midline gluteal cleft. It's common. We think approximately 26 to 100 per 100,000 adolescents and young adults suffer from this condition. It results in considerable physical and psychosocial morbidity during an already vulnerable and oftentimes stressful time period of life. The disease has highly variable presentations and historically wide-ranging treatments as well. The disease can have frustratingly high recurrence rates regardless of the treatment. It's important to note also what pilonidal disease is not, and that is a congenital cyst. We oftentimes still hear this nomenclature. Pilonidal disease is an acquired rather than a congenital condition. This frequent misunderstanding does have important implications for treatment, as one is, of course, less likely to offer an excision procedure if there is no congenital cyst to excise. In the next few minutes, I'll discuss a surgical approach to pilonidal disease. To be clear, this is just the approach that we take at Nationwide Children's, but it's not the approach. And there are certainly variations at other great hospitals around the country. So we have a centralized pilonidal clinic occurring to which all pilonidal disease referrals are sent. The clinic is led by 2 pediatric surgeons with a team of excellent nurses as well. Other pediatric surgeons in our group do, of course, provide incision and drainage procedures for acute pilonidal abscesses. But otherwise, all pilonidal disease is managed by the pilonidal clinic. Of course, you might imagine this is an arrangement that is easily agreed upon by the other pediatric surgeons, so that is oftentimes not difficult to manage. So on one side of the clinic, the pediatric surgeon, myself or my partner, is seeing new and follow-up patients. We have 2 lasers in our clinic, 1 diode laser and 1 YAG laser. And while the surgeon is seeing follow-up and new patients on one side, the nurses who are actually credentialed and trained to do the laser hair removal are providing laser hair removal simultaneously on the other side of the clinic. That laser hair removal is done under the guidance of a laser therapy order set that's placed by the pediatric surgeon when the patient is deemed ready for laser treatment. So the surgical consultation for new patients begins with a history and careful examination of the gluteal cleft. The gluteal cleft is shaved with clippers and baseline pictures are obtained. Fitzpatrick skin type is also noted. Rarely, drainage is still required for persistent pilonidal abscess, and even more rarely, examination finds an alternative diagnosis like folliculitis, or perhaps a perianal disease associated with inflammatory bowel disease, and I'll say that's one of the few circumstances when imaging would be recommended. Otherwise, pilonidal disease is identified as expected. So some patients present like this with minor symptoms, little evidence of active disease. In those scenarios, we might recommend proceeding directly to laser hair removal. However, more commonly, we find patients like this, where there's more evidence of active disease, such as these open midline pits. You can see there are also evidence of a prior incision and drainage. Or sometimes there's more advanced disease with not only open pits, but also this common fistulization that we see here, typically occurring superiorly and can also lead to sizable granuloma formation. Sometimes even more extensive disease is noted like this, with deep sinuses filled with hair, inflammatory debris, and granulation. These patients, unfortunately, have often had prior attempts at excisional procedures at referring facilities prior to coming to us, as can be seen in these two patients with large scars evident. In some of the most severe cases, like those with open wounds containing large volumes of hair, in particular in patients who don't tolerate much in the way of bedside wound care and pit picking, we might proceed directly to a GIPS procedure. However, in most cases, we instead initiate a trial of medical management. So medical management consists of education regarding adequate nutrition, minimizing trauma to the gluteal cleft, initiation of twice daily saltwater baths, and careful daily cleansing of the gluteal cleft. Hair removal with clippers is provided at each of our pilonidal clinic visits, and additional shaving is also encouraged at home between visits. We also discuss the use of chemical hair removal when open wounds are not present, and we encourage and provide laser hair removal when the wounds are healed. We also provide local wound care in clinic, namely pit picking, meaning inserting forceps or hemostats into the open wounds to remove hair and other foreign material, as much as patients may tolerate, as well as silver nitrate application when excessive granulation is present. So when medical management alone is successful in healing the wounds, we then encourage the patients to go on to complete laser hair removal. However, when patients are not seeing adequate improvement with medical management alone, it's when we schedule a GIPS procedure, also known as minimally invasive trephination. So we do our GIPS procedures in the operating room. The patients are positioned prone, ideally doing so on their own before receiving sedation. So we do the procedure under MAC whenever our anesthesiologists are on board with that idea. We use varying sizes of punch biopsies to remove the midline pits and small sinuses. Cautery is used to excise large superior fistulas or granulomas when they're present. The wounds generally do connect subcutaneously, and curettes are used to debride the subcutaneous space of hair, other foreign material, and inflammatory debris. The wounds are treated with hydrogen peroxide. Others have described the use of crystallized phenol as an alternative. The wounds are irrigated with saline, the walls of the cavities are fulgurated with cautery, and the wounds are dressed with gauze and tape. We do not ask the patients to do any packing of the wounds. We just ask them to keep dry gauze wedged into their gluteal cleft until all the drainage has stopped. The wounds just are allowed to heal by secondary intention. We emphasize continued twice daily saltwater baths and daily cleansing to keep the open wounds free of new contamination. Patients are seen back in clinic ideally every 2 to 4 weeks until healing is accomplished. Sometimes at those visits, additional pit picking is necessary or silver nitrates needed in the post-op period to encourage wound healing. So this would be a relatively common progression, moving from the left in the pre-op state to the immediate post-op appearance next, and then to the second, and to the first post-op visit there, and then the second where healing has been accomplished. And we find that in most cases, healing of the wounds takes about a month or 2. So sometimes GIPS needs to be repeated if there's persistent failure of the wounds to heal, although this is relatively rare. And otherwise, we proceed to laser when the wounds are healed. So the other surgical options worth mentioning are the so-called excisional type procedures. These include excision with primary midline closure, excision with healing by secondary intention, and excision with off midline closure, the options being the flaps and cleft lifts. However, we found that these options are only rarely necessary. Mostly we encounter the frequent and unfortunate consequences of these procedures after they've been performed elsewhere, meaning kids coming with large open chronic wounds that are really difficult to heal. So I think there are many unanswered questions regarding the management of pilonidal disease. We are currently collaborating with other surgical groups, including Stanford, to establish a common standardized terminology regarding the severity of disease. So it's easier to compare apples to apples across studies and across centers. It's unclear when it's most efficient and beneficial to proceed directly to a GIPS procedure rather than first to do a trial of medical management. We would love to see better dissemination of the GIPS procedure to the adult surgery world, where there still seems to be resistance to GIPS procedure as an excellent treatment, and where there's persistently high use of excisional procedures. And finally, which our next two talks will cover, what do we do with those pesky chronic wounds that just won't seem to heal? And what exactly is the best role and timing for laser hair removal in these kids' treatment? And how can you set up a laser hair removal program at your hospital if one doesn't already exist? Thank you.
Hello, I'm Candace Fredette. I'm from Phoenix Children's Hospitals, and I'm here to talk about those pesky pilonidal wounds that won't heal. I'm a family nurse practitioner, and I'm wound care certified. We find that the wound certification has been invaluable in our clinic, that after an IND or a GIPS procedure, if our surgeons are not seeing improvement, in 3 to 4 weeks, they're transitioned to the wound provider. As a wound provider, we can actually look at the wound, decide what proper wound healing type of dressings to be used, and also we hammer in that education of nutrition. Once the wounds are healed, then it's also our job to try and teach families how to prevent this from coming back so we never see their booty again. And then our job is also to manage the wound vac therapy, both inpatient and outpatient. And believe it or not, yes, we do use wound vac therapy on our very large pilonidal abscesses. These usually come from patients that have had long-standing disease, that have had no interventions, or we have a high population of HS patients in our region for some reason, and a lot of uncontrolled diabetes. So we will start by bringing them inpatient, doing the debridement, and might need multiple debridements before we put on a wound vac. Once they are tolerating their wound vac therapy and we feel that they can be transitioned to home, we set up a home wound vac system, and then they come back to the operating room as an outpatient for dressing changes twice a week. Once we get enough tissue coverage over those raw nerve endings, we do a trial of 4% lidocaine. We'll go in an hour before their procedure under anesthesia. We'll infuse 10 mLs to 12 mLs into the sponge and let it soak in there for 45 minutes. We call it marinating. And then we take them to the back, and under anesthesia standby, we do a wound vac change. And if they are successful, they are transitioned to our outpatient setting. And that is done until we get it healed. Now, wound vac therapy for pilonidals, let's just face it, there's 3 main problems with it. A, the smell. People cannot handle the smell. I tell my patients, go pick out dryer sheets, wrap your machine around it in the bag so it doesn't smell as bad. Number 2, that seal is the hardest part. I've taken Eakins rings, folded in half into a semicircle, and molded it around either the anus or the difficult part with very little, and then go over that with a hydrocolloid just to create a dam. That way your sponge and your provided dressings are able to attach. And please do not put the trackpad back there. That's just causing added pressure injury. You've got to move it and do a trackpad to the side. And please alternate your sides, left and right, each change to prevent other skin issues. Now, you have a pilonidal wound. It's not healing. It's one of 3 things. A, granulation tissue. B, you have wound products, but it's still not healing. Or C, the wound has bioburden in it. And that is a very common place to get bioburden, because the goal is to get this healed in 3 months before it becomes chronic. If your wound has granulation tissue and you feel like you're silver nitrating constantly, I have some providers that we send silver nitrates home with parents to keep silver nitrating it. Have you ever considered using triamcinolone or clobetasol, the same stuff we use on our G-tubes? I've started putting it into packing and packing it into my wounds, and it actually shrinks the tissue, allows that trapped hair from the granulation tissue to come out with their sitz baths or pit picking. And the beauty is the wound will still shrink, that I've had to transition to them to still use the clobetasol, especially in those top tracks on the gluteal cleft, with umbilical tapes. That's packing as well. It's not just used in the OR. Use all products that you can have. This might take more time than the quicksilver nitrate, but it's actually more tolerable, and the kids actually like it better because you're not torturing them with the burning. Number 2, are you using the right product? If you don't have a wound specialist or know your entire wound formulary, you could be using products that is making the wound worse with moisture, with creation of bioburden. And not only that, some of your products, the kids, they have a sensitivity to it. I didn't realize this, but I had a patient that had severe reaction to just silver impregnated dressing or manuka honey. So keep that in the back of your mind. Because remember, the people before, you have to have the Goldilocks look at it. It has to be the right product for the right wound bed in order to heal this faster. Bioburden. Bioburden is our skin has bacteria on it, and it actually goes into your wound and creates a fake sense of skin coverage. So your body stops healing. It just doesn't. So the appearance is super shiny. It can be pale. And then there's many products out there to minimize bioburden. Some of the easiest is, instead of doing a bath, I have the parents irrigate the wound with a hypochloric acid. There's trade names underneath if you want to take a picture, because I'm not allowed to talk about them. And have that be irrigated or put in the room and let it sit for 5 minutes before doing your topical dressing. Next is what is going on with everything else. You've done A, you've done B, you've done C. Did I go past one? Anyway, is your nutrition right? Let's face it, we have kids, they eat throughout a house and home, but they're only eating enough to grow. They're not eating enough or the right kind of foods to actually heal their bottom. So if you find that they're healing because they're nutritionally challenged, you might need social work to help with finding options. The other thing is, they don't have bathtubs. So showers are not enough, and those sitz pans, let's face it, it's only around the anus. It's not getting up in there. It's not soaking enough. I have them go to the store and pick up one of these guys. I tell them, take the kid with you, put them in. If they fit, put it in your shower. You fill it up, put your Epsom salt in it, and now you have a bath. And my older kids that go off to college, that's what they take with them. Okay, and do they have support at home? They really need a booty buddy. That's what we call them. Who's your booty buddy? Who is doing your wound care? Okay, because sometimes the parent that's bringing them in is not the one doing the wound care, so please allow yourself to be videotaped as you're doing the wound care so they can see it, because it's like anybody else. What'd the doctor say? I don't know. So have it there, okay? And or you might need to change your appointment times or days once in a while just so that parent can come in with you. And then we have other issues. All right, you are not going to heal a wound if one of these 4 things are not fixed. If their diabetes are not controlled, you're going to have extended wound hit. If you have HS, you can start treatment now. You can start the minimal treatment of doxycycline, BID, clindamycin lotion to those flare areas, and get him on chlorhexidine soap to wash those areas. Because let's face it, it takes 6 to 8 months to get into derm. So you can start, that's the #1 starting treatment for HS. Hormone imbalances. For my girls, if they keep having chronic issues, I put them on birth control. If it's a boy, I actually have a candid conversation and ask them if they're taking any male enhancement drugs or not steroids, but testosterone, because they want to work out. So keep that in the back of the mind. Boys are sneaking that stuff too. And do they really have a manifestation of Crohn's? I had one patient that had a non-healing wound until we realized it's Crohn's. It was a linear cut that just wouldn't heal. So we sent them to GI. All right. The other thing is, for success, is put down step by step your wound care that you want them to do. Take a picture. This is my template. I then alter it to exactly what I want them to do so that they have a step by step when they get home. And the kid can be involved and say, Mom, you forgot a step. So because and it comes on my end of visit summary. So it comes down, it's like, we're supposed to do this, this, and this. And then I always hammer into them that they need to eat. They need to have some sort of supplementation, whether it's shakes or anything else, vegetables, proteins, just to get the right nutrition. And once they start getting the right nutrition in, your wound will heal a lot faster. And these are my resources.
Hi, my name is Clara Brajano. I'm at Stanford Children's in Palo Alto, and thank you for this opportunity. I have no disclosures. So why do laser hair removal therapy in patients with pilonidal disease? So studies show the benefits of laser hair removal reduces recurrence of pilonidal disease. It improves healing, enhances hygiene, it's minimally invasive, and it's a long-term solution for more permanent reduction in hair growth. Commercial laser centers were not meeting the needs of our pilonidal patients. They did not target lasering the gluteal cleft. It was too expensive. It's not covered by insurance, and there was no medical oversight, and the compliance was poor. So in our institution in 2019, we incorporated laser hair removal therapy into our pilonidal clinic to meet these needs. So how to get a laser? Investigate whether any lasers already exist in your facility. We found ours in a closet. Check the clinics like derm, plastic surgery, even the operating room. Ask your biomedical engineering department for inventory of all the lasers in your institution. They will give it to you. When developing a proposal, understand your clinic's capacity and potential. Evaluate current patient volume and expected growth. Identify your referral sources and determine if the demand justifies implementation. Assess whether it's a worthwhile investment of time and resources. Connect with other medical surgical specialties. So who else might benefit from using the laser in your institution? You'll garner more support for this. So check with dermatology. They may want to start helping you out with managing the hidradenitis suppurativa. ENT, if they're doing microtia repair, they're using it for their flaps. Plastic surgery for any vascular lesions, and even urology if they're doing gender therapy and bottom surgery. Connect with manufacturer reps for product details of the type of laser that you want, the pricing points, and extended warranty options. And definitely inquire about the extended warranty options because sometimes they do fail. And determine what the electrical power requirements are if you're in a new building or in an old building. In crafting a proposal, identify the decision makers. Follow up with your division chief, your clinic and service managers. You really need their support. Make sure clinic administration and dedicated staff like the medical assistants are available to support the laser hair removal procedure days. Seeking out funding sources, if that can be incorporated into the clinic budget. Apply for grants. If you find an old laser, as we did, you can ask to trade up or upgrade to a new laser. There are options to rent, to own a laser, so those are available as well. You will also need approval from your laser safety committee and comply with safety protocols. And through the clinic space planning committee, you need to assure clinic space, room scheduling, treatment time slots, and also determine a secure storage space for the laser. Because let me tell you, when people find out that you have a laser hair removal somewhere in your clinic, you will find random people getting to it. Check your fellows and your residents. Biomed will also handle ongoing maintenance and act as a liaison for your laser manufacturing representatives as well. So now you have a laser, now what? So who will perform that laser procedure? So truly either the provider, so MD or APP, or the nurse. If you are an APP or an RN who will be doing the laser, policies and procedures must be created and credentialed with annual competencies. They may be required to have a laser certification, which they can obtain through organizations called the National Laser Institute. Anyone using the laser, including physicians, Anyone using the laser, including the physicians, must receive a laser training certificate from the laser manufacturer. And in our institution, we even had our MAs sit in on the training as well, so they knew how the machine worked. And they can't do the laser, but we wanted everybody in the clinic to understand that. In the RNs are performing the laser, a written order from the MD or APP is required. So the structured laser hair removal therapy plan can be initiated via an order set. And for billing, so this is the hot topic for creating a laser therapy program. Billing will vary by institution. Due to differences in state, regional, and institutional policies, you must review this with your compliance and billing teams. The RN who performs the laser, their visits will likely be charged as a hospital facility fee with an E&M code. And typically, MD or APP is in the clinic and available as needed. For the MD or APP who performs the laser, this means the MD and APP must deliver the laser treatment to bill. Their direct involvement is required, not just oversight or supervision. Initial consultation triggers an insurance pre-authorization for multiple sessions, which can also vary by insurance. The billing code, typically what we use is 17999. It's an unlisted procedure code, but authorization is inconsistent and may need peer-to-peer. It's helpful to state your treatment as medical laser hair removal therapy and include a lit review to the insurance company during pre-authorization to justify medical need. And when the pre-auth team questioned this with us because they said, what's all this research, right? We said, no, just submit this along with the pre-auth and let it take care of itself. We just wanted them all to have that justification for the medical need. So once you have a room or a clinic set up, when you're setting up your laser room and supplies, you want to find a room without a window, but if you have a window, make sure that there are opaque coverings with no gaps to prevent any laser escape. Ensure that the glasses are laser specific and match the laser wavelength. You may need a laser plume or a vacuum smoke evacuator if needed, depending on the type of laser that you have. A supply cart for wound care supplies is recommended. That's on wheels for ease of movement and efficiency. And to help decrease pain and discomfort with the laser treatment, we use cryotherapy. It is an investment of another $10,000 to $15,000. However, it's quick and effective. In some lasers, it's already incorporated. We have used lidocaine topical creams, but it takes too long and is not as effective. And surprisingly, just a simple ice pack ice in a Ziploc is quite effective. We consent patients for up to 10 sessions, stating the risks and side effects as listed here on the consent form. Each patient completes a skin type form to obtain their Fitzpatrick score to use for the laser settings. And after each laser procedure, we remind the patient no hot showers or sauna, hot tubs, or direct sun exposure for 24 hours, and that they can use lotions, take a cool shower, and monitor for side effects. So expectations with laser hair removal therapy. Studies show the recurrence rate drops to nearly 0% when hair burden is reduced by at least 75%. So our goal is never going to be 100%. This takes about 4.8 to 6.8 sessions, depending on the skin and hair type. Laser hair removal is performed during the anagen or active growth phase. And so for back hair, this means a treatment every 6 to 8 weeks. Visits are structured to allow 20 minutes for the provider. Patients are instructed to arrive 30 minutes early for before and after shaving photos, shaving the gluteal cleft, and the laser procedure itself. So again, laser hair removal is not permanent. Dormant hair follicles can activate over time, and typically regrowth is lighter and less dense. And patients may need spot treatments or reinitiation of therapy over time. So when to laser? As long as the patient is asymptomatic of their pilonidal disease and they deny any pain, it's fine to laser. Those with gluteal pits, chronic tiny wounds, and/or granulomas, as you can see here, are all fine to laser. Laser hair removal around asymptomatic chronic wounds and midline skin pits with no pain, no infection, or active drainage is also fine to laser. So this patient was seen in consultation and underwent his first laser treatment. He was instructed to continue to shave and do daily warm soaks and wound irrigation. When he returned for his second laser treatment 6 weeks later, we noticed wound healing and wound contraction. He was still a surgical candidate since he continued to intermittently drain from his granuloma, but what was helpful is that we didn't need to make an even wider incision when taken to the OR for debridement, excision of granuloma, and pit picking. So this is that patient at surgery, and about 2 weeks post-op, his wounds were healing well and it remained asymptomatic, so we resumed laser therapy. The photo on the right is typically what we see 1 to 2 weeks post-Gibbs procedure and excision of granuloma, who's ready to also resume laser therapy. So laser hair removal contraindications. Of course, for any signs and symptoms of abscess, infection, or symptomatic open draining wounds, or any complaint of gluteal plane, we will not laser. We will not laser anyone with a rash, a yeast infection, skin irritation, or folliculitis. We also have not found any issues with skin sensitivity after lasering patients on Accutane. And oftentimes, sometimes the kids even forget to tell us they are on Accutane. So that's kind of how we found out, okay, you're not having any issues. So we've continued to be able to laser in that respect. Thank you for your time, and please feel free to reach out to any of us if you have any further questions.
Okay, we have a few minutes now if anybody has any questions.
So my question is getting the institution to actually get on board and buy the equipment if you don't already have the equipment in another department is usually the biggest barrier to starting laser. So do any of you guys have a business plan to share? That would be helpful.
We don't have a business plan, I would say, to share. I think one argument to make is just the effectiveness of it. Like there's more and more coming out showing that it is effective. So I think you can make that argument that this is an effective treatment that decreases recurrence risks. I think we will now be updating our lasers. So right now we have 2 sort of older lasers. We are going to update that. And we will be making some variety of business plan because the clinic is exploding because, as I mentioned, people are more than happy to send you these patients. So I think we will be making a business plan, although we haven't really had one.
Got it. And then
But just really quick on that too is in our institution, we actually had, because we did find a laser removal, a laser, we actually did a trial clinic just to see how it would work for them. So that was somewhat helpful because we knew who was going to come in and be compliant with that regimen.
besides for the upfront cost of the training of the nurses or NPs and also the buying the lasers themselves, what are the upkeep or like maintenance costs? Are there any?
So when you actually do purchase a laser, each manufacturer will offer for the first time a free training. It's incorporated into the cost of the laser. So in that respect, you have to really try to garner as many people to attend that training because it can range up to about $3,000, $5,000. They're going to make their money somehow. And we found that because we've been doing it since 2019, retraining other people, they charged us another $3,000 for their training. This last time we said, can we videotape it? So we've kept it online so that we can train subsequent people, and due to turnover, then we don't have to keep paying the manufacturer for that. So, and consider writing it into your protocols because then you don't have to necessarily physically be the manufacturer. The manufacturer doesn't have to physically do the training. You can follow up with online training or someone who has gone through the training to oversee that compliance. So.
Thank you. Super helpful talk.
Yeah. I'm sorry your second question was about maintenance. So the biomedical department, the biomedical engineering department, they are obligated to maintain the maintenance. They'll check it regularly. And then if there's any issues, there is a manufacturer representative that you can call anytime. And that's why extended warranty is super, super helpful. The first time we did not get it, it was super expensive because one of our handles broke. When we renewed the contract, we said, okay, we'll take a 7-year warranty plan.
And it might be needed if you're sharing that laser with another department. It rolls, it breaks. So really get that extended warranty. So if you're bringing the laser from one clinic to another,
Yeah.
it's well worth it.
The other thing is have your medical assistants, when they're cleaning the laser, the regular maintenance, have them sign their name off as cleaning it, because what we found is damages do happen. Multiple people are using it. So we wanted to have people who are touching it be accountable for it. And because someday you have 35 patients and you're like, the handle's broken or the crystal's scratched, so you want to see who is the last person who is responsible for it.
Yeah, hi, I'm Kelly Austin from Pittsburgh, and I really appreciate everything that you've made and the contributions you've made to this, the field of pediatric surgery and pilonidal disease, because, it's one of those ones where I used to go kind of kicking and screaming into the room thinking, like, what more can I pull out of my armamentarium to help these poor patients? And now you kind of can feel hope, and, but I did want to say that I was in that situation where our institution had to start from scratch. We do have like plastic surgeons doing laser in the operating room, but it was actually intense pulse light and not necessarily the very best hair removal. And so I went to Stanford, spent some time with them, figured out how to do this. And we had a business proposal. And I don't have the numbers or what that, but you can go through the number of patients you see. We do get pre-authorization and reimbursement, and we use the 1799959. You have to add the 59 to the end. And in Pennsylvania, I don't know if it matters. So that's using medical laser under 30 minutes. There's a 30-minute to 60-minute, and then there's greater than 60-minute code as well, that extension that I don't know the numbers by heart. But anyway, I think we just proposed the number of patients we see, the number of OR cases we do, and actually, like she said, patients come out of the woodwork, and all of a sudden, the instrument is paid for very quickly. And as far as our training program, we actually had the company train. There's modules as well. And ultimately, we had a couple champions then that basically are sort of our medical staff committee that for competency lets us kind of sign off on them after so many observed. So they do, most of our patients or most of our providers did go to the meeting, but they didn't have to do this very expensive outside the hospital course. So it actually surprisingly seamlessly has happened. And one of the problems we did get into, I researched the right laser. We went to our committee, we got approval. We went to them, there's this other committee, that biomedical committee that has to, or purchasing committee that has to decide. And that at the 11th hour, they said, we don't really like this company. We have poor kind of responsiveness from them in our adult world. This is a big institutional UPMC thing. And we would prefer that you go to a different company. So we had to go to a different company that's extended maybe 6 more months' time to go to the different company and get their approval. But it was all about contracts, negotiations, things like that, that you think you're on your way because you got approval in January. Well, by the time you go to this other committee, it ended up getting done in November. So I'm just saying, think about that, because that was just the reality of making it happen.
And I think Kelly also reminded me too, is that I think in the beginning, you were doing most of your lasers just in the beginning in the operating room. And so if you don't have a laser, your OR, if you bring in a case to the OR and you request devices, you can request a laser because they will rent it for your procedures in the OR. And that way you can start to garner and see what sort of, and then they'll realize, oh, this rental process is so expensive, it's worth actually purchasing one
And
or
then we
renting
do
one
all
to
our
own.
lasers in the clinic, except for there are a few patients that are just too, or you try to combine with some pit picking or GIPS, but there are some patients that are autistic, some patients that are just incredibly PTSD, that I still do some procedures in the laser in the OR. But unfortunately, what she was saying about we don't we have two different things. We have an in-hospital thing and an out-hospital thing. And unfortunately, we don't take our ped surgery laser to the OR because of it's a different community. So and I hate to say that, but maybe someday, but that's it's something to think about. Yeah.
Hi, great talk, everyone. I do have a question about triamcinolone cream that you're using. How long can you use that therapy? I thought it was kind of limited.
Oh, sometimes I do it once a day, and then it can be up for 2 weeks, and then I have them take a week off and see if we need to restart.
So you do give them a break. Okay.
Yep, I do give them a break. Yeah, because then you want to reset the time, and sometimes it just needed enough. And then during that week, you get actually better wound healing. I still would have them do packing, but not with the cream. I would have them hold the cream and still, because you still need something in that wound to tell the body it's a wound. Because let's face it, if you don't have something there to irritate, it's just like a splinter. You need something there to irritate it. And the butt crack, once you don't have something in between, I use a rolled gauze to keep it separated to remind the body there's still an open wound, because it just hides underneath there, and that's where the chronic wounds come from, and people not realizing it's back there.
All right, thank you.
Great talk. Jennifer Timmons, Kalamazoo, Michigan. Question regarding billing, because I know you guys said that you have been able to submit stuff for prior authorization and that kind of thing. How often do you run into insurance companies not paying for it, and is it covered by Medicaid, that kind of thing? There's children's special health care.
So we actually realized in 2019 when we started, we were sending all of them through pre-authorizations, and it wasn't that often. And like I said, I think I was just a little OCD about making sure insurance companies understood the medical necessity, and I coined everything in my E&M, for the E&M, like everything on my note to be medical therapy. Everything was medical laser hair removal therapy. Just that simple, they go based on, either they're doing it with AI now or whatever. It's your note. You really need to really have a very thorough note for E&M. But we really didn't run into too many, and we did find that they were reimbursing. And then compliance kind of came into the picture, and then they held our bills for a little while, and and holding those, we weren't getting the reimbursements that we were getting, and basically we're sort of eating the cost. And so we're kind of in a point where, because our clinics have grown, do we let our nurses take over to start doing them more? Because it is time vested for your providers, because you could be seeing patients on the side too, and we do that as well. But both ways work. I think you guys are doing the RN method, but you guys have also received reimbursements, right? So
Yeah.
yeah,
I think everywhere is figuring this out.
yeah.
Because it's new. Initially, this started as a research study, and so we were not billing initially. We were billing just for a established patient follow-up visit, which really, once the study was finished, wasn't really accurate. So there was a brief period where the surgeon, often with a surgical trainee, were doing the laser treatments, and then our billers did want us to actually bill for it a professional fee. And that's where we used a comparison code like Claire mentioned. It was very brief that we did that, because then we started to think about it. You really don't need a surgeon doing these laser treatments. It doesn't really make a lot of sense. If you don't have a laser at your hospital, you're sending them to a mall or a salon, right? So like, you probably don't need a surgeon doing these treatments. So we thought our nurses were more than capable of doing it. They were trained, credentialed in it. And so then we switched to, we are not billing any professional fees. It's simply a facility fee that the nurses put in. And for that, our billers wanted us to use, essentially they called salons and asked, what's the price if we wanted to do laser hair removal, and just to have some benchmark to kind of shoot for. And since we've been doing any of this billing, we have not had issues with insurance companies balking at it. The randomized control trial has been published showing that it decreases recurrence rates. I don't know if that's why, or they just don't fight it, but we have had zero issues in the insurance companies balking at paying for it.
And for
And,
those,
and that's why consider including your lit review when you're submitting for pre-auth, because most of the people on the other end will be like, what's all this? Well, it has your JAMA paper, it has all the things that justifies the reason for doing the laser for medical therapy to treat pilonidal disease. And so because of that, I don't know if maybe that's why I haven't gotten, and you will get the peer-to-peer reviews, you know, they'll call and they'll let your office know, or they'll let your front desk staff know. So.
and it generally covers like the multiple treatments? Like
Yeah,
what
so
the
that's
problem with that?
variable. Yeah, so we've had insurance companies and parents telling us like, well, they've offered me, they'll either go by 90 days, you know, so how many treatments can you have within those 90 days? So that's sort of an unlimited because we set the time for every about 6 to 8 weeks. Or they'll say up to 6 sessions or up to 3 sessions, and then they have to do another renewal. But once they approve that first one, we haven't really had any issues for them to continue as long as you send, you send your note. And so that's why you really have to have a very robust note.
Thank you.
Quick question. Yeah.
I was just curious, making a take poll of everybody in the room. Are people doing the GIPS procedure in clinic without sedation or with sedation? So with sedation,
We're in the OR.
We're in the OR.
and I'm sorry, are they doing in clinic without sedation? The majority of them. Because my partners are still taking the kids to the operating room, and I found it's actually 90% of the kids who aren't anxious, I can just do it in clinic. So I was curious to see what the experience is.
Yeah, we do ours in the operating room, but I do think it's sort of a gray zone between pit picking and a GIPS procedure. So we're pretty aggressive pit picking in clinic. You could probably call it a GIPS procedure. Once we kind of have reached the max of what they'll tolerate, if we're still not healing, then we would do the GIPS procedure. And for that, we do it in the operating room.
All right, I think that's all we have time for. Let's give them one more round of applause.